you. So I'll be talking about my research that I'm doing for the Masters in Health Professions Education. And just to right at the start, acknowledge Ian Cooper and Susan van Schalkwyk as my supervisors and of great help in doing this research. Before I get into it, maybe just some thoughts on recruitment and retention, and that's specific for doctors in rural environments. So there's been many interventions investigated over the past few decades, including exposure to rural environments in undergraduate years as well as postgraduate, creating financial incentives, selecting people from rural backgrounds, and others. But two things we know from the literature is if you select people from rural backgrounds, and if you expose undergraduate students to rural environments, that increases the chances of them environments. Yesterday there was an excellent presentation about, I forget the person's name, about see where people end up and why, regarding those that were selected from rural backgrounds. And there was many similarities from that presentation to what we found. So this is what we know about specifically educational interventions when you expose students to rural environments. And these things are principles or advice for people that are considering it. But it's to admit students from rural backgrounds, select students that have an intention for primary health care to work there, and then also to employ family physicians as teachers and preceptors, expose students early on, early exposure better than later. And teach a curriculum that's very specific to rural practice. Doesn't make sense to teach specialist hospital skills to somebody that wants to go and practice rural. And then also to build in some flexibility. And financial incentives that was more in first world environments, but yeah, also sometimes attract people to make it more feasible. With this slide, I just want to show a model that just shows some of the complexity in people's decision making. It's no simple matter. You do this and then the doctor will practice rurally. And this is a model that was created by the Australians from that publication. And just show something. I mean, family is very much part of it. What's happening in terms of your family, that affects people's career choices. And a whole lot of other external factors. With our research, we look very much more to the health professions education, so just to be aware that there's many other factors that play a role. And these have actually also been investigated for doctors in South Africa. So just a bit about our program and where I fit in. So I'm a coordinator of the LIM, or the longitudinal integrated model, which is a longitudinal integrated clerkship. And in this model, we train final year students for an entire year at a district hospital. And the research that I'm going to talk about includes these sites which you are seeing there. So these are small district hospitals within the Western Cape, between 50 to 80 beds per hospital. Oops. And those numbers just indicate the number of students that we can put there per year. So Steve mentioned that my interest is tracking of students, and we have 3 programs in Stellenbosch University where we have a longitudinal placement of students for an entire year, and actually 4 now that since physiotherapy has joined that list, but we are investigating currently 3 studies, and I'll be talking about the last one, which is a qualitative exploration of the career journeys. But we're also doing a cohort study as well as a cross-sectional one, where the cohort study is looking prospectively to where students end up and what the quantitative aspects regarding their careers, and the cross-sectional study looking retrospectively. But hopefully at the next conference, I'll be able to tell you more about that. Just shortly about longitudinal integrated clerkships. It's being recognized as a good model for training medical students because it has many educational benefits as well as recruitment and retention benefits regarding that. In some environments, they've already been doing it for 35 years plus. A lot of research being published in Australia and America. And yeah, there's 95 longitudinal integrated clerkships registered. If you go to the CLIC website, which stands for the Consortium of Longitudinal Integrated Clerkships. Okay, so at present, there's 3 medical schools in South Africa that have an exposure of 6 months or longer. UCT and Stellenbosch being one of them, and Walter Sisulu, the other medical school. And for us, this is now 10 years after we started with our LIC. And for us, it's time to think what's happening, where do our students end up and for what reasons? Trying to understand what the influence of our LIC has been on our students. So this is a qualitative study. It's of social constructivism it's underpinned by that principle, trying to understand the influences of people, looking at in-depth understanding of what led to their career journeys, as well as looking at the different layers of what those factors have been. I conducted interviews via Zoom, so this was sort of towards the end of COVID last year, and we asked our participants to make some drawings of their career journeys. 5 of the 8 doctors were willing to put their hand on paper and be creative. And then my perspective as an insider was in some ways facilitating because people knew me and they were comfortable talking to me, but I'm also aware that it could have influenced their answers and they might have said things that I wanted to hear. So looking at the study's demographics, we had 78 LIC graduates from 2011 till now. And we decided on 8 interviews. We thought that would give us enough information. But with the inclusion criteria of them being at least 5 years postgraduate, we thought that would help us to get an idea of where they are in their careers and what their future careers were going to be. And then there were 5 females, 3 males, 4 of them in registrar posts, and 2 doctors working rural at that stage. Just some more information on demographics. So you can see how far they were postgraduate. Half of the participants were married, and 3 of them had children. So this is the model that I've designed and trying to understand all the various factors that had an influence. And this is basically from the raw data. But we're not going to be able to go into detail of all of those factors. Very much focusing towards the bottom, where we look at the educational aspects that had an influence on the doctors. So we initially had 4 themes. I'll be presenting 3. And these were the main things regarding the LIC's influence and how it worked or changed people's thinking about their careers because of our training. So coming to the drawings, this is some of the creations that they've made. And initially I thought I would be able to interpret them and use it as part of my data collection. But like that dandelion, it blew away. Yeah. a range of autistic skills amongst doctors. So coming towards the first theme, which was feeling prepared for the career journey. And it's well known, and I can reflect back to my own experience, maybe you're the same, is as you exit the door of the medical school that you feel quite unprepared for what lies ahead. And I specifically mentioning, thinking about when I stepped into a rural environment, I felt even more unprepared. But encouragingly, our students felt very prepared for this career journey. Students said, I think it's the LIC training that helped me in the sense that maybe I wouldn't have considered taking that rural post that sort of kick-started my career in the MO in psychiatry. Had I not experienced living in a small town before, I think it's sort of, I would say, knew what to expect, but I was already accustomed to some of the things I was experiencing in Ladysmith. So it was not really new, some of it. And that's something that came through quite a few times, is that being in a rural district hospital as a student took away the strangeness of rural. It wasn't something out there far or unfamiliar. But our time in the LIC side gave us an idea of what it's like to be doctors. Students got an opportunity to have a meaningful contribution and to feel the doctorness of being a doctor and not just being an observer. And what the reality is, another thing I've noticed is once you've been there, you notice how simplified your time in a tertiary facility actually is in terms of being in the LIC or being in a primary level person. The buck stops with you. You've got to be the decision maker, and it's very easy to just pass on the responsibility in a tertiary facility, and it can hinder your development as a professional. Something that really stood out is how having responsibility influenced how they saw themselves, but also how they changed over time. Then looking at acquiring a new motivation and new career goals. So this doctor used to be a consultant in the LIC site. When I was a LIM student, hearing about his story, how he had transformed the hospital, but also being there and working with him and seeing how he worked, how he was able to do so much as a clinician, it made me think, let me just say, just watching others ahead of me work in situations where they're not necessarily deemed to be favorable or the most ideal situation, but the impact they had on their communities, I think for me that became the drive. So the importance of having a role model, then that for us, that just highlighted that when you select a site, that you be sure that there's the right role models. But I think, yeah, I'm happy with the government sector, and I think I'm needed there. The amount of patients that are there is just a lot, and maybe I'd be more used there than I would be in the private sector. So what we also saw was a shift in what is now important. My career as following something I'm interested in, or my responsibility to what do I have to do to help this community? Who else is going to look after this community? And then there were some unexpected influences, things that we all, our students, did not anticipate, where there was the desire to go rural, but not necessarily the opportunity. Initially, I thought that I went up to be in a tertiary setting, but I enjoyed the more high-risk obstetrics, enjoying critical care. But I was so conflicted because I wanted to work in a rural setting and serve in a rural population, serving women who are generally or traditionally underserved. So this student thought the best way to help people in rural environments would be to be specialized. in advanced obstetrics. But the registrar training took her out of that environment where she wanted to be. I did ComServe at Mamelodi last year, and only 3 of us have jobs. The rest, including the rotation-based graduates, are still unemployed and frantically looking for jobs. So I think job security is a huge factor that people don't tell you about when you're undergraduate. Of the 8 people I interviewed, only 1 of them did not have an issue with job security. Seven of them at some stage had an issue. They were uncertain about their job, what's going to be next, or they had to take something temporary or something completely different to what they wanted to do just to have an income. So to try and pull things together, it just became so apparent that the confidence that grew in the students as they became skilled in participating and becoming part of a community of practice was crucial in them seeing themselves as doctors, but even more so rural doctors. And their what we call personal identity formation. And what was also interesting from literature is to see that these environments specifically instill the values of altruism and social responsibility. And then when people see that they can make a contribution, they start believing it and then function better in those environments. Versus the student that's 5 weeks in a rotation and then before they can really be incorporated in the team or think or reflect about their contribution or interactions, they have to move on. And then there's important aspects for us to think about when we have transformation as a goal. For people that are used to city environments, to get them to think rural, to be in those environments and to aspire to be a rural doctor. And specifically thinking about creating space to think and reflect about it. Then something else that I've been thinking about is the importance of nurturing before the realities. So now junior doctors are early on exposed to rural environments, sometimes for the first time in their internship when they do their 6-month family medicine rotation or in their community service. But the LIC is a safe space to work in that environment with supervision, where their mistakes are still covered. And then there's the problem of posts. How do we come to a space where this is not breaking down the hard work that we've been doing? Just some questions that has been stimulated by this work. I mean, we set out a time for when to interview these students, but is this appropriate? Would it be better to do it a bit later? Is it still too early in their careers? Many of them being in their registrar posts, we don't know if they'll return to rural or not. And more, it seems like for me the issue is how do we select students better for LICs? Because rural exposure transforms many people. Some people take into it. And sometimes it's a 4-week exposure or 6 months, or I don't think it necessarily has to be entire year, but it's who we select. Who will be open for that transformative learning? And then I'm wondering if there's a need for rural specialist programs. If we can train people like the family medicine training program, is there a need for more programs to have rural specialists? Can one train an internal medicine specialist in rural for the entire course, or surgeon, or a rural generalist? Yeah, so to conclude, we know from this and from the literature that rural longitudinal integrated clerkships do support professional identity formation and transformative learning, and this can have an influence on their career choice. And then in our current healthcare system, we have factors that limits the options for adults. So when you're finished with your community service year, there's no guarantee that you can get a job in a rural environment. And then there's a need for postgraduate training. Having said that, maybe you're not aware of it, but the Kwanda Center for Rural Health is offering a postgraduate diploma in rural health. It's starting next year. Applications are still open. Somebody told me to put this in there. Okay. And here's some key references if you're interested in the topic. Thank you, everybody.
We have a minute or two. Any specific questions to Francois now? Yeah, Liesel, go for it. Just repeat the question here in front of the mic for those who are online.
Francois, what kind of registrar posts were they in? And what disciplines were they going into?
Okay, thanks for that. So two of them were doing radiology. One was doing actually two of them doing obstetrics as well. No. I think one surgery, two radiology and one obstetrics. Yeah. Helmut?
Yes. Frederick, you asked the question whether 5 years of the training was long enough or not long enough. I wondered whether the question shouldn't they really go into longitudinal study? That one, as they leave the program, that one looks maybe at 3 years, 5 years, 10 years, and then also see how that influences, how that changes, and whether being part of a program where you need to reflect how that influences further career moves.
Yeah, thanks for that. So currently our cohort study is a 5-year study, that being a quantitative study. But yes, I should probably revisit even this cohort in another 5 years' time.
Madeline?
I think I mentioned earlier, we had a Rural Seats Cafe on Tuesday with our ILCC students at WUSU. So they do 6 months at the second part. The 5th year medical students do 6 months. And so we've had a theme of why go rural. And then we had these students and we asked them the questions, would you stay in rural? So these are kids who's grown up in Lusikisiki and Tolo. They then went to WUSU, which is a very rural university. That's from the beginning, you're placed in clinics. And these lot were at Butterworth, 10 students at Butterworth Hospital. And it was interesting, the first instinct in the discussion was, no ways, none of them were going to stay. But that was that emotional thing of, I've come to medical school, I've got a degree, it's opening the world for me. And what I want to do is I want to go to the cities and I want to go overseas and I want to go and specialize and do all these amazing things away from where I grew up. What was lovely about it, though, is that, and that came out later, is that the students said they've never had the opportunity to actually reflect on this question. Because when we really went through it, you could see that's the immediate first thing of what will happen when I finish. And so the question more was, will you come back? And that was more the issue. So a lot of them liked the idea of going off, and we've all done that. I ended up in England for 10 years. And then once you go, where do you want your kids to grow up? Where's your family? Would you come back to rural? And that was interesting. So a lot of them imagining them going off in their 20s, but actually coming back in their 30s. So when you're talking about, when we look at the effect of this question, and then Lungi asked the question, which was very powerful, when you leave here, and your mom and the people live in Lusikisiki, and you leave to go and work somewhere else, which doctors are going to come and look after your mom? And that was a really, and they all went, no, nobody will come. And there was that, so there's that feeling also of not to just say they must all stay, but can we get them to come and finish off their careers, the last 20, 30 years of their lives in rural?
Yeah, Thanks for that. Wow.
And I want to add something about the research, Francois. You know, there's this confining effect where you are deliberately recruiting students who have a rural background. So what is the effect of rural origin and what is the effect of the rural training? And can you differentiate the two? So educational research is very difficult. You can't do double-blind controlled trials. And it's the answer is in the qualitative nature, the qualitative methods, because to differentiate those two is impossible, really. We know that we are preferentially selecting students of rural origin. I mean, that's one of the selection criteria. So what is that effect, and what is the effect of all the educational strategies that you put so much energy into?
Yeah, we don't know.
We don't know.
Thanks.
Okay.
Thank you.
Thanks, Francois. Another round of applause.